Hello, everybody. Welcome to my YouTube channel, Nurse Ed Simplified. Here we are bringing together various topics which are of nursing and medical importance, and also which will help us in caring for the patient, preparing for our future examinations, and of course, at the same time, empowering ourselves. So, before we start for today's topic, kindly like, subscribe, and share my channel so that we can increase our support and empowerment. So, we move on to a very interesting and a much asked topic, requested topic by various students, and one of them is Emergency Severity Index, what we call as ESI. What are the objectives of the teaching? I would like to my students or my listeners to identify the 5 level triage scale of the ESI, describe the ESI triage algorithm, identify the resources that would affect the algorithm, discuss the process involved in patient assessment on the ESI triage. So, what do you mean by a triage and how this term came? It is derived from the French verb trier, which means sort or choose, that is to filter. In earlier times, triage was widely used in military settings to sort out their casualties, which used to come in bulk, and sorting the wounded soldiers in order to establish treatment priorities, whom to treat first. The emergency nurses are equipped to triage patients and determine the priority of care based on the physical, developmental, psychosocial needs, as well as the factors which influence the access to healthcare and patient flow of the emergency care system. So, when you have a bulk of patients or casualties, you have to sort them and then look for which one to prioritize and which one we can keep it, on a later stage for us to look into. This is the idea or the concept is adapted from the Emergency Nurses Association Standards of Emergency Nursing Practice. What are my goals? The goal as per ENA 1999 is to rapidly gather sufficient information to determine triage acuity. The triage nurse is expected to obtain complete relevant history, vital signs, including pain scale assessment, along with the unit department specific questionnaire. The triage is expected to be completed within less than 5 minutes, but not more than 8 minutes. The sorting should be followed immediately. It means immediately you triage and then the care should start to commence appropriate and prompt treatment. So basically, to get the right patient to the right resources in the right place and at the right time. So the ESI triage algorithm decisions, they are based on 4 key questions. When you have a bulk of patients arriving, you have these 4 questions to sort out in mind. Is the patient dying? Is this a patient who shouldn't wait? How many resources I will need for this patient? And what are the first vital signs? That is, vital signs, they provide you baseline data. This is the ESI triage algorithm. What is in black is it requires immediate life-saving intervention. That is anything where you will see that the patient is not breathing, no pulse, apneic, will need intubation. That is level 1. Next, if it does not, it will go down to level 2, but still you need to identify if the patient is in a high-risk situation, confused, lethargic, disoriented, or severe pain and distress, because pain scale is also one of the vital signs other than the blood pressure, heart rate, temperature, and RR. Pain is also one of the vital signs. If yes, it will go to level 2. It is still very important for us. When these criteria don't meet, and then you sort it out to how many resources are now needed for the patient. For example, if you see that the child is less than 3 months and the heart rate is more than 180, RR is more than 50, and saturation is less than 92% on room air. it is level 3. When you see that the child is between 3 months to 3 years and the heart rate is more than 160, RR is more than 40, and your saturation is less than 92% on room air, he is also under level 3. And 3 years to 8 years, more than 100 is your HR, and RR is more than 20, saturation less than 92%, he is also a candidate for level 3. When you have only one of the resources being used, we will discuss the resources, then that is level 4. When none of the resources are being used but the patient needs to be here for observation, it is level 5. Now, when do you make a decision? First thing, determine if immediate life-saving intervention is required. How do you do that? You assess the A, B, C, D. That is, you assess the airway, breathing, circulation, disability. Next, what are the emergency medications you are going to give to save the patient? If it is a sedative, or if it is a tranquilizer, or it is a muscle relaxant, you cannot discharge the patient, or you cannot keep him waiting. Other hemodynamic interventions. IV, supplemental oxygen and monitoring, ECG, they are not under immediate life saving. Okay. Assessment of AVPU. What is AVPU? Alert, or to verbal response, or to pain, or unresponsive. Now, unresponsive, no, sorry, is defined as a patient that has no verbal communication or is not following your commands. That has happened recently. I mean, it's not that he's like patients with dementia or patients who are bedridden, they will not respond to you. This is the baseline, right? But someone who is developed this new change, like is not responsive to your commands, that is called acute, or requires some noxious stimuli, like you have to give him some pain, some sternal rub, or some sort of pain stimuli to get his alertness back. Or if it is a high risk situation, that if you put him on the last bed, you need to observe him, like a patient with suicidal tendency. Severe pain distress is determined by clinical observation, and patient rating of greater than 7 is considered as important, very emergency. Now, ask yourself these few questions. How is his airway? Is it obstructed, partially obstructed, or totally obstructed? Unable to protect his own airway. That is an emergency. Now, if none of these, go to breathing. Is he apneic, or is he already intubated, or his SpO2 is less than 90% on room air, or is experiencing severe respiratory distress? Next, we come to circulation. Is he have a pulse? Is it pulseless? How is the rate? How is the rhythm? How is the quality? Drugs. What sort of drugs are you giving him? Or are you giving him some drugs to maintain the hemodynamic stability, like something like inotropes or something? So in short, the question that you're asking is the patient dying? Yes, immediate attention. No, it will go to level 2. Aggressive life-saving interventions. Which of these interventions are you going to use? Like airway, breathing, intubation, surgical airway, or like CPAP, BiPAP, BVM mask ventilation, whatever. Defibrillation, external pacing, or you need a chest needle decompression, or hemodynamics. How is the hemodynamics? You are needing fluid resuscitation bolus. You have to give him immediate blood, or you are giving some vasopressors or inotropes. These conditions, they are important to save a patient's life, so this changes your decision. So they are all under level 2. And control of major breathing. When we come to the next part, that is level 2, level 3 decision, consider the resources the patient will require. Review the vital signs. I already discussed the dangerous vital signs, huh? So if it is more than 8, like as we discussed, in adults, if the heart rate is more than 100, breathing is RR is more than 20, and SpO2 is less than 92 on room air, they go under level 3. Now, other than the danger signs that you can see that I have mentioned here, other than these, If a pediatric comes with these conditions, they are also an emergency. Like 1 to 28 days of age. If the temperature is more than 38 degrees C, also it comes under ESI level 2. 1 to 3 months of age, and if the temperature is more than 38, it comes under ESI level 2. 3 months to 3 years of age, and if the temperature is more than 39, it comes under ESI level 3. Now, ESI level 1, I'll give you some short examples so that you can relate it in your clinical field. A cardiac or a respiratory arrest, overdose with a respiratory effort of 8 breaths per minute, severe respiratory distress like gasping or agonal respiration, patient came with anaphylactic shock, critically injured trauma patient with very low GCS and danger vital signs. They are ESI level 1 even though it is not life saving. So it will automatically come under ESI level 1. We are talking about critically injured trauma patients. Next, if you have patients with chest pain and at the same time they are diaphoretic, palpitation, heart rate is more than 180, he needs to come under ESI level 1. Unresponsive with strong odor of alcohol with history of diabetes mellitus, it will come under ESI level 1. Severe stroke needs airway protection, it will come under ESI level 1. Now we come under decision point review B. Is this a high risk situation? Now you need to identify if this is a high risk situation. Like, a very brief and a quick interview is necessary. You will not have to take a full set of vital signs. You can do it simultaneously while you're taking a history. But you cannot keep the patient waiting, which means that if you keep the patient waiting, he might deteriorate. So time and treatment is very sensitive, and there is a potential major life or organ threat if you delay the treatment. Those questions are: is the patient confused, lethargic, disoriented? How is the GCS? If it is less than 8 by 15, he is not a patient to be waiting. Is there an acute change in the LOC? Is this a situation where the brain is structurally or chemically compromised? Is this a patient in severe pain or distress? Now, we know that pain is subjective. Now, pain, for example, it relies on the clinical observations and physical assessment, like kidney stones, a burn patient, or an oncology, or mother in active labor, compartment syndrome. Their pain has typical clinical observations and physical vital assessments. Distress, like patient has committed homicide or there is a case of sexual assault or grief reaction, this also comes under the same criteria of level 2. Now, how many different resources are needed? Now, if it is like as we can see, 2 or more resources are being needed and the vital signs are not, they are under the danger sign, it goes under level 3. If one resource is needed, it will be going under level 4. If none, it will be under level 5. Now, how do you decide the resources? It is done by an experienced triage nurse. Like, for example, a patient came to you with a chest pain. So, you know the resources that are needed: an ECG, lab, and assessment, vital signs. So, these are the resources which are generally determined by an experienced triage nurse. Based on the standard of care, depends on the acuity of care, sensitivity of the case, and different physician privilege. Now, identification of resources. This is very important to understand. Your labs, your ECG, X-ray, CT, MRI, ultrasound, IV fluids used for rehydration, IV, IM nebulized medications, specialty consultation, like if it is a simple laceration procedure, if a complex procedure where you need conscious sedation, they are resources. What are not your resources are, like, you cannot consider history and physical, including pelvic examination, as resources. POCT is not a resource. A saline heplock is not a resource. PO medications, peroral medications are not resource. Any sort of immunization like tetanus is not a resource. prescription refill, phone call to the primary care physician, simple wound dressings, or just checking your wound, use of crutches, splints, splings, they are not considered as resources. So the more resources you are using, for example, a patient came with chest pain. Now you see the vital signs and now you see the resources that are needed. Lab, X-ray, you may need a CT, and you will need medications for IV fluid or something that comes under. So already occupying 3 or 4 resources, right? So the patient is in level 3 automatically. Now if he uses only one, like he came for a wound on the foot and he needs it's a laceration and he needs to be sutured, that's resource 1. So it's level 4. So you can, only, and when with experience you know that. Now, sorry for the delay, what are the not life-saving resources? Like any sort of, like any things that we are using and we are not using as a life-saving procedure are your diagnostic tests such as lab, ECG, oxygen monitor, IV access medications, pain medications like a nitroglycerine, antibiotics, heparin. They are not considered as life-saving resources. They help you or they aid in your assessment or in your treatment, but they are not life saving. Life saving is something that you will need an intubation or you will need something to control the pattern of breathing. So examples of resource, as I said, CBC and your examinations of the blood, one resource. CBC and a chest x-ray, it will be considered as 2 resources. Chest x-ray or abdominal x-ray, it will be abdominal, any sort of series you want to do, 1 resource. Chest x-ray and a CT scan, 2 resource. If it is a CBC, CT scan, ECG, 3 resource. So if you use 3 and more than 3 resources, it is level 3 automatically. Now, as we explained everything, now I will give you a short 2 scenarios, one after the other. And in the comment box, I want you to tell me what is the level, ESI level for the 2 patients. So first patient, we see a patient, 79-year-old male. He was found on the bathroom floor. The family heard a loud crash in the bathroom, and the patient was found in his underwear, and the toilet bowl was filled with dark colored stool. Vital signs on arrival are BP 70 by the diastolic, not just barely palpable. Heart rate is 128. RR is 40, and his family tells that he has a history of atrial fibrillation and he is taking a blue pill to thin his blood. That is something for anticoagulant, a blood thinner. Case scenario 2 is like a patient arrives with history of wrist pain, history of fall in the hallway after slipping on ice. His vital signs are BP 111 by 68 mm of Hg, heart rate is 86, RR is 20, there is no obvious deformity, and pain scale is 5 out of 10. So these 2 scenarios are very different from each other. I want you to identify which ESI triaging it will come under, level 1 and level 2 or level 3 or level 4. Please put your answers in the comment box and let's discuss. Should you have any questions, you can put it in the comment box. I'm most happy to answer to them. Thank you so much for your patience listening and have a great day. Please do like, subscribe, and support the channel so that we can keep empowering our nursing fraternity. Bye bye. Take care. Have a nice day.